an amazing day today. It's fantastic to reach this point, and a huge achievement for the many people who have been involved in the trial, from the trial volunteers around the world to the almost 2,000 staff who have been working on it in the 3 countries. And if you have to give the second doses just a few weeks later, then you can't give the first doses to so many people. You've got this huge deployment problem. So if you extend the window and you've got some protection in that window, that actually allows us to start getting things under control more quickly. So I think it makes huge sense what they've recommended. And it's really supported by the data. We have the data showing that we've got protection with an extended window. The immune response data show that as you have a longer gap between the 2 doses, you do see higher immune responses. And of course, that's not a surprise. That's what we see with many vaccines, that many schedules have 2 months or 6 months between the 2 doses, because after the booster, when you've given time for the immune response to mature, you get a bigger response. So I think it's in terms of what you're preventing, that 70% figure is preventing symptomatic disease. But we also know that in that period, in fact, anyone from 3 weeks who was vaccinated didn't go into hospital, didn't have severe disease. But we are also looking at the milder disease where there's about 70% protection. What I think the Commission on Human Medicine's chair was trying to point out was this point that if you look at the immunity after the second dose with the extended dose interval, it tends to be higher, and that should track to higher efficacy. And that's where he came up with a maybe 80% figure, because that's as you extend the interval, immune response would be better, and maybe the efficacy would be better as well. Well, I think there's very good safety data. We've got safety data on a very large number of older people, including people with other health conditions that the MHRA have looked at. The more limited information is on the efficacy in the older age groups. And that's just because we recruited older age groups later. And so they're still sort of accumulating cases in the trial that will allow us to do further data cuts during the course of the next month or so, to give us more confidence in what the efficacy looks like in older age groups. The immune response data looks good in older age groups and similar to those in younger age groups. And the limited information we do have in the older age groups also is in the right direction. So there's no particular concern, but we do need more data, and that's coming. And of course, AstraZeneca also have a huge American trial with already 20,000 people enrolled. So I think they'll have a lot more information in the months ahead on older adults too. So this is part of this emergency authorization. We've got some data today, and there is more to come. We can't throw away our face masks because vaccines that are in a vial and not in someone's arm don't do anything. And so until we've reached a point where we've got all those who are vulnerable in our societies vaccinated and protected, we're not going to be throwing away face masks. And of course, the question of how long that takes is all about supply, public policy, health systems. Those are things for governments and the actual manufacturers to work on together. And I know here in the UK, AstraZeneca are working on hour-by-hour plans with government to make sure that the rollout happens as quickly as possible.